Okay, Bismillah ar-Rahman ar-Rahim. Good evening, everyone. On behalf of Saudi Patient Safety Center, I would like to welcome all of you to this special and important webinar. My name is Professor Ibrahim Al-Sarra. I'm Professor of Pharmaceutics and Pharmaceutical Biotechnology at College of Pharmacy, King Saud University, and I will be serving you today as a moderator. You will be hearing a presentation from Dr. Fakhr Al-Ayubi. She will be speaking to us on the polypharmacy, how we should avoid it. Dr. Fakhr is the president of Cardio Clinical Pharmacy Group at Saudi Heart Association and the vice president of Arab Association of Pharmacy Progress in Egypt. And she is an intensivist cardiology clinical pharmacist at Department of Cardiac at King Saud University. She is also adjunct assistant professor at College of Pharmacy, King Saud University. She is currently working at King Fahd Cardiac Center. It's an honor to introduce her. Now we are moving along to our session. Please, we welcome Dr. Fakhr Al-Ayubi to deliver the presentation on this very timely subject. Please notice that the question will be at the end of the session, and please post it in the Q&A icon so our speaker will answer them gladly after we finish the presentation. Dr. Fakhr, the floor is yours.
Thank you very much, Prof. Ibrahim, for the nice introduction. Thank you very much, Ustad Hiba and the team, the organizing team that took the lead, honestly, to have such a great organization for this important event. I think part of us already has practiced pharmacy. And I'm not going to say only clinical pharmacy, because even pharmacists and the outpatient pharmacists in the world everywhere, even in the community pharmacy outside, they are facing this problem. And why is it a concern for us? Because the most important thing for us is the patient safety. And as you know, it's the World Patient Safety Day. And we are just having a series of activities to work very hard on giving an alarm about the importance of the safety of this patient that we are treating and we are taking care of. I want to thank for our participants who really give us the valid time of their, let's say, relaxed time to join us in this activity. And what I'm trying to go over today actually is talking about the polypharmacy. Now, why is it a polypharmacy problem? Why is it an issue? We will go through the slides now and we'll try to come over the facts that is it's a problem. Then we will talk about what is a polypharmacy. And of course, it's very important for us, maybe because as a pharmacist, we will say the role of pharmacist, but it's not only the pharmacist's responsibility. Honestly speaking, it's the responsibility of the healthcare practitioners. But being a pharmacist, maybe that was the idea behind talking about our role. And there's a very important message that we have to take to our practice. Now, we're not here just to get CME hours. We're not here just to talk about a problem. We're here to solve it and then take it back to where we work, because we are supposed to solve the problem in our practice. Now, there's something important that we have to focus on. The major characteristics of those patients who have a polypharmacy. Now, why I'm saying that? Because always we have to diagnose the problem. Diagnosis starts by at least knowing who is the patient or the group of patients that I should concentrate on. Older patients supposed to have the problem because they have multi, of course, drugs, multi-disease, and lots of comorbidities. That's why they might face the problem more than other patients. Also, by the way, some of the definitions said even the young patients. Why? Because young patients, not because of the polypharmacy only, it's because of somebody who should take care of them. But again, in the Saudi community, they did a study and they saw out of the data that our patients are category either above 60 or 12 years old. Imagine the category of 10 to 12 years old. Why? Again, we will talk about it in the coming few slides. The most important thing that I think we face is that The cardiologists in Saudi Arabia are very well trained. We cannot say anything about our training and our experts. They treat our patients with the most evidence-based guidelines. Endocrinologists, they are the best, and they treat our patients according to the evidence-based guideline. Family medicine, they are the greatest because they are the one who see the patients and sure they treat them on the evidence-based medicine and the best guidelines. What about nephrologists? They are the best also, and so on. The most important thing that happens, or the problem that we are facing, that each one of them treat the patient as if he's only having a heart, or if he's only having diabetes, or only having a kidney, but they don't think about the whole body, the whole patient. This is where problems come. So we need to talk to each other. We need to look at the patient as one entity, as one human being, not only just one organ. The other important thing that we are facing in Saudi Arabia, which is a unique problem in our culture, the herbal medicine. We believe a lot in herb. We believe a lot on the effect of herbs. And some of our older patients, they take herbs without telling us what they are taking. Unfortunately, this will interact with the chemicals that they are taking. So now you can see, at least we have some tips. So we know our pathway, we know what we are facing. And when we say about polypharmacy, at least I need to know the definition. Now, according to different guidelines, according to different, actually, honestly speaking, scoring system globally, some of them say more than 6, more than 9, more than 4. For us, the one that we are actually using and the one that we are practicing in Saudi Arabia, more than 5 medications is considered polypharmacy. Is it an OTC medication? Is it a chronic medication? Any chemicals or herbs that is more than 5 pieces, it's considered polypharmacy. This is where you label the patient. This is a polypharmacy patient. This is where you need to focus on. Now, some facts about polypharmacy and about the elder patients. 40% of them, they have more than 5 medications of the elder patients. 70% of them from the 12 years old, as I told you, and this is in a statistic that is related to global, and the Saudi Arabia match this statistic. Now, 40% of the old pharmacy patients, they have OTC medications. Believe it or not, these are some of them the harmful interaction OTC medications or herbs that might even threat the patient. Some of the patients, they might take, for example, paracetamol, and they consider that, okay, this is not important. I'm just taking a painkiller. Again, to interact with the warfarin, to interact with antibiotic, it's even harm your kidney and so on. So again, see, now we are going towards the problem. Why I'm concentrating on that? Because 15% from those patients might have complications of this polypharmacy within the 5 years where they are chronically using the medication. Another fact, for example, the garlic. I believe most of my friends, family members, and parents, they believe in garlic. They say it's very helpful. It's going to help my heart. It's going to help me getting better. Even in At-Tibb An-Nabawi, we heard about it, and it's very good. Again, interact with your blood, actually, and sometimes it might cause bleeding. And that's why it has to be given with observation. And that's not all, with a specific amount also. We all heard about omega-3 and the fish oil and how miracle it is and how it's going to help your heart and decrease your lipid. You believe it or not, it will interact even with your medication. And all patients should be considering this. If they don't consider that, you should introduce this to them. Now, some of the doctors do not have time to ask their patients, what is going on or what are you taking? Now, it's your role, again, to talk to your patient. Tell them, what are you taking? What kind of medications you are on? What kind of herbs you are on? Again, put it part of your questions. The most important adverse drug reaction comes from the polypharmacy. And we all know that because, again, all of them might act on the same organ, which is the kidney. They might even interfere with the liver enzymes. And it's very costly interaction. It's very costly adverse drug reaction that, and otherwise, we could have taken this money and treat more patients rather than treating the problems that we caused by polypharmacy. So do you have a role in that? Now we know the problem. We actually labeled the patient who might have this problem. We even labeled the concern about us thinking about it. And also we said that there's a kind of problems that we could come over by talking about herbs and OTC. So let us see now, what did we do? Honestly speaking, in the university where I'm working in now, we said we want to see first in our cardiology clinic, are we doing a good job or not? Why cardiology? Because not because it's only my specialty, it's because, you know, cardiac patients and elderly patients, which is a chronic disease, they will face the polypharmacy more than others. So we took the peers characteristics, which is one of the scales that it's used globally to label the patients polypharmacy or not. And the peers actually were matching with our definition, which is more than 5 medication. And we're talking about patients who are visiting the cardiology clinic. Now, the most important thing that we want to validate this tool. You cannot use any tool and you just go ahead and you use it on your patients. We did some validation because peers also is one of the characteristics that could be used, but is it applying to our Saudi patients? And by validation, we found that it does. And it really worked very good about improving the prescription in the elderly patients. It will work on this screening tools, but this is more into this tool, but peers will at least give you the screening tools for your patient. And the most important thing is that the peers character is the one that really match with our Saudi population because they considered the age of the patients, they considered the disease of the patient, and the most important thing, the beliefs of the patient of having OTC and herbal medication. So again, we went with the definition of the peers and we said, okay, we will look at the following: the drug-drug interaction, drug-disease interaction, and the adverse drug reaction in the older patients, which is our patients, cardiac patients, and the duplication of a class for medications that should not be given together. This actually was the most important characteristics that we looked at. The other thing is important for us is the multidisciplinary team, because in the cardiology where we are working in King Saud University, it's usually not only a physician clinic, it's with pharmacist, with nurse, and sometimes with educator. So again, this will play a role and it will actually be part of the evaluation. We focused very much on the geriatric patients. And the other thing is that the pharmacist knowledge that is visiting these clinics, and they are a part of it. And the most important thing is that the sites that we're getting our patients from. Why did we choose the primary care? Because these patients has been already evaluated by a primary care and they labeled them that they are chronic, complicated patients that should be referred to cardiology. Other patients who are not that complicated were not part of the study. Why is that? Because I want to see if I have a cardiology patients and these patients were prescribed by cardiologists, not even only primary care, which is sometimes just general medications. Now we are talking about selective, specified, and expert people in the cardiology department. And we were looking at the drugs like aspirin, beta blockers, because again, depends on the patient disease. We will see are they on these medications or not. We also considered using the proper medication, not only the complicated or the ones that are over-prescribed, even the chronic medications they are on. For example, aspirin. We want to evaluate those patients. Are they evaluated? Are they followed? Do they have a GI problems that has been already on board? Are they really treated for their GI or not? Is it real that they have to take aspirin, or is it over-prescription? For example, the beta blocker, and are they really taking the proper beta blocker, which is selective or not selective, and so on. So I don't want to actually go into details because actually we trained our staff 2 months before the start of this study. We told them what to do, what kind of medications we are looking for, how many numbers of medications, what is the side effects they should look at, and what's the interactions they should look at. After doing all that, we went to the clinic, and from there, actually, we looked at the patient's profiles and interviewing the patient themselves or the healthcare practitioners, especially in Saudi Arabia. We know that most of our patients, especially the elderly one, they don't come alone, they come with a family member. Our cardiac center studied actually the years on the spot and 5 years before. And we found that only 21% were getting the appropriate medication. Again, what do I mean by that? Appropriate, the drug, right dose, right patient, with the right follow-up. Very important for us was the follow-up. Now, it's really shocking for us because we're supposed to be a tertiary center. We're supposed to be with very important and very educated professors, updated. And that's not all. We have also a multidisciplinary team on board. So are we doing our job? That was the question. Now, the most important thing that we are facing actually with our cardiac center and the cardiac patients coming in our center is the drug-drug interaction. See, I'm telling you now, polypharmacy, one of its very crucial elements is the drug interaction. And then comes after that, of course, the contraindications. And then after that, are they taking the proper treatment? And there's the side effects. Are we taking care of the side effects? In the end, of course, there was some problems with the doses of the medications or even the duration. For example, we know patients who take, for example, statins for 1 month and then they stop because they think that's only for 1 month. Or if they are taking antihypertensive medications with a very low dose and they think that this is better for them, so they will not have hypertension. Again, a lot of mistakes and a lot of details, but again, that was the chart, that was the results of the study. You can see now 80% were not taking the appropriate medication. Imagine, as if we're not doing anything in the hospital. And that's not all. We are having lots of interactions with the patient's medication because of the polypharmacy. And we are not educating our patients enough to tell them what interact with what and what to do. Now, number of causes for inappropriate drug use was, as I told you, number one was either one cause or two cause. This is actually one of the criteria of the peers review. They will even assess more. Are we having only one problem, like one drug only give the side effects, or is the patient taking 4 problems or 5 problems? Now, you can see almost 26% of our patients, they have 2 causes or even more. Again, look at the number. Some of them have even 5 causes of their side effects and their inappropriate prescription. And this is really very scary because if I'm having this amount, like you can see, if you put them on together, more than 40%, 45% of our patients who come to the clinic, who are visiting a physician, who are prescribed with the proper medications, they are taking their medication through the healthcare providers, are getting 5 or even 2 causes of problems of inappropriate prescription. And this is really very, very harsh. Because again, where's the pharmacist? Where is the healthcare practitioners? We are not doing our job. And unfortunately, that was the result of the study. So from that, we assigned pharmacists for the clinics. They have to attend the clinics. They have to work very hard on the patient's adherence, not just only to the medications, to the instructions, to the counseling part, and also to the treatment plan. Because if I'm going to sit with the patient and explain for them what is the importance of adhering to their appointments, labs, and medications, it will save a lot of money. It will save a lot of problems. The other important thing is that we should work in a team. I believe in one man, actually. It's a one-man show that will not work with any patient's care. Patient safety means the whole healthcare practitioners working together. It will never work if you are just working alone. The other important thing is that we should work on the prevention, the detection. We know now the group of age that we should tackle. Doesn't mean the others are not important. All of them are important, but we have to put a priority for the efforts of the specialized people in drugs, what to do. The most important thing also is the time that is important to measure the response of the patient. It's not good to see a patient after 9 months, and I discovered through the whole 9 months, he's taking the lisinopril in a wrong dose. This is really very harming for the patient. The other important thing is that if I can make the polypharmacy little, or if I can shrink it by giving a fixed tablets, for example, by giving a medications that is from one class only, one medication, by making sure patients will not have a difficulty in following the instructions of my drug. Like some of the time in the outpatient, we'll tell him, take this in the morning, take this afternoon, take this in the evening. Put yourself in this patient's shoe and see if you can really honestly do that. Try to make your instructions that is really matching with his lifestyle. For example, after Fajr prayer, that would make his life easy. If I can separate the drug to only 2 doses only rather than 3. if I can combine some of the medications together without interaction, but with a proper adherence, or even help the patients with alert, with alarming system. I do believe that we don't listen to our patient. And I'm telling you that from an experience. I believe we used to dispense medications in the outpatient, and we have only 8-hour work. And with 8-hour work, we have to dispense 2,000, 3,000 prescription. Imagine what kind of listening are we doing? What kind of even talking to the patients are we really doing? So that's why we need more pharmacists to be in the clinics. We need them to sit and talk to the patient. Please try to listen to your patients, listen to their questions. They're not asking you because they just want to have fun. They're asking you because they want to know how to take care of themselves. We need to listen to their symptoms. I know that it's the doctor role to diagnose the patient, but some of the symptoms, it's from your drug, not from the disease. You have to justify that. You have to be careful. Again, you have to listen to the patient, what medications they are taking, instruct them to bring the medications with them to the clinic. If they are taking OTC medications, what kind, for example, which is a very famous example, the Clarinase. We all know that Clarinase is one of the drugs that is an OTC one. We take it just to come over the flu symptoms. But it's a drug that might cause hypertension. And if it's a cardiac patient, it might even work very bad on the left ventricle and increasing the overload, which again will decrease the perfusion of the kidney. So look at that. It's just a simple drug that he can even get it from the supermarket. It's not even from the pharmacy. But look how bad it is on this patient's health. So sit and talk to your patient. If they have herbal medications, don't attack them. They're supposed to trust you. They're supposed to come and tell you, I'm taking this and that. For example, I know ginger, maybe through the Corona COVID time, everybody was drinking ginger, but we have to make sure we're not overdosing ourselves. We're not toxing ourselves, because even ginger, it has a limited amount. More than that, you might even affect your white blood cell, your RBCs, your lymphocytes. This has to be transferred to the patient properly. Now, I think one of the problems that we are really facing is that most of our patients, they like to listen. They like to talk to you. But in the end, you have to know something. Only 30% of what you say, it will stick to the patient's mind. But 70% they will not remember once they leave your clinic. So try your best to talk to them, okay, explain to them, but also you need to write this with even handwriting, with a note, with whatever suits you and your patient, so that when they go back home, they make sure that they are listening well and they are memorizing well. One of the other things that we really are facing in our cardiac patients is that our cardiac patient does not come back to follow unless they have a problem. And if I have a patient who have, for example, heart failure, you not see them regularly unless they have a fluid overload and they cannot breathe, they cannot sleep, and then they will come back to you and they will tell you, oh, I cannot sleep. Why? I'm not taking my medications. See? So again, try your best to screen those kind of patients in your clinic. Who are the ones that really need extra effort? See them after 2 weeks, after 1 month, if you can. Even follow up those patients. What we are trying to do these days now, we're trying to activate our WhatsApp, which is, again, it's an easy application. It's free. Everybody has WhatsApp. And what we're trying to do is just to transfer the message properly, follow the patient at home. Unless they need help, they can be even treated at home. The other thing is that we also need to talk to the patients about the seriousness of a polypharmacy, why we are trying to avoid a lot of drugs, not because our drugs are bad, it's because some of our drugs might harm you if you don't take them properly. Now, very important thing is that we need to put in mind something that even in geriatrics, it's very hard for them to swallow a pill. So if you can decrease the number of pills, it will be excellent, and make sure that it's comfortable for them to swallow. The important thing also for us is that we need to know further knowledge about those patients and their understanding of their medications. Sit and ask them questions. Do you know what your disease is? Do you know what's the harmful effect of not treating this disease? do you know this drug is not a red tablet only? This is a drug that works on your blood pressure. And this drug has to be given every evening. And this drug has to be regular. And if you stop it, you might have this and this and that. So this kind of communication between you and the patient will make it easy for you and for them to follow the proper instructions, so they will not come back to you with complications. They will come back to you only for a follow-up, which is exactly the ideal thing about the patient safety. We want them to be safe, taking the medications safely, and be followed safely with our experts and our physicians. The other important thing is that if you see any kind of extra information or extra side effects, or an event that you really think it's because of a human error, please try your best to report that. Reporting is not because we are blaming anybody or we are blaming each other. It's because we want to put an alarm that this drug that is given twice daily is not properly followed by the cardiac patients. So we'll prefer, in this case, if there's evidence base that supports both drugs, we will prefer the drug that's given once daily. For example, if you see a lot of patients who are not adherents to the diuretics, you will not report that because it's known. But what you will report that these patients who are taking the medications properly, they are not responding because they have resistance to this type of medication. And it could be because of the manufacturer this time, not because of the patient. See? It's very important for us to differentiate between one and another. The drug-related problem, it's actually one of the very important things that we are focusing on today. The other important thing for us is the drug adverse effects and the withdrawal of the event. Some of the events, and this is actually beyond this presentation, we actually classified adverse drug reactions to different categories. Some of them do not reach the patient, but some of them reach the patient with no harm. Now, the most actually serious one is the one that causes death to the patient. And this is actually what trying here to exercise. When you do your exercise on those ones who are not harmful, at the end, you will catch up those ones who will cause death to the patient. And this is what we are trying to focus on with these activities. Now, the interaction between the healthcare practitioners, it worked very well. And honestly speaking, in our center, it really improved the patient adherence from 30% to 70% to their medication. It also actually gave us a space where we can sit with the patient. We can also make sure that those patients are really following the rules. And on the other side, we had more space, more time to talk to the patients on the details of their disease rather than trying to talk about the side effects and how to come over the side effect. Now, again, it's very beautiful, very rewarding. I really advise everybody to do it. And in the end, you are the one actually expert in the pharmacotherapy. So you're supposed to the one to detect the problem and report it and sit with the patient to explain it for them. Then sit with the healthcare practitioners, because we want our practitioners to be also updated and right to the point. Again, these are the types of patients. Now, today I will try to focus, of course, on the geriatric patients. But again, there's some patients that you should put in mind that do not really stick to their medications. And you can see the age group is a problem. The gender, we can see that females actually more compliant, and unless she's pregnant to their medication than male. Male, maybe they like to be on pain better, or they tolerate this feeling better. The education, of course, the lack of education, and even overqualified people. These are the two categories that we should focus on, because when you know a lot, you might not be able to adhere to your medication. The financial matters, and now it's a problem, especially after COVID. الحمد لله حكومتنا الرشيدة ادتنا الفرصة طبعا to be treated in the government. But again, it's very important to put your money in the right place. So financial matters, and sometimes when I have the same effect from two drugs, for sure I'll go with the cheapest one, but I'm looking now at a cost-effective value rather than a cheap drug. Attitude is important, because some of the patients are actually cautious, and they might not even take the medication because they think that it will cause this and this and that. On the other side, you will find patients who are over-compliant. They might take 2 or 3 medications. They think the more medication they take, the better outcome. Another problem that actually we should also work together on is the overwork and the load in the clinics. And I know most of us might even face a problem of overbooking the patients. But if you have a team there, try to use your team. I'm sure it will be a better outcome. The other one are the delay in the appointments. Now, when you have a patient who really doesn't come on their appointments, or who come late, or who come after their appointments, these are the patients that you really should focus on. The family and the relatives are very important. Alhamdulillah, in our culture, we have a lot of family members that take care of their parents and of each other. So maybe it's not a big problem now, but be careful, because again, in some cultures, it is a problem. The role of pharmacist, I do believe in patient education. Now, the more you educate your patient, the more there's awareness, the more there is flyers or programs, or even posters that talks about the problem, which is a polypharmacy problem, and the medications and the proper use of it. I'm sure there will be a better outcome. Again, social media is very important now. Why not use it? And why not to have an umbrella that we can talk from? And it could be in Arabic and English, even Urdu, even Filipino, whatever language that we can use, especially that we are the country of Al-Haramain. We are the country that everybody from the Islamic world come to us. And now we are open even in the siyaha or thaqafa. So I'm sure that we need these efforts to be done properly. We need an umbrella for that. And again, sites are there. People are waiting for us, waiting for our knowledge. We can do a lot in different sites, and the pharmacist's role is very important in every aspect, in every chronic disease. And I do believe that drug use is the end of the therapeutic consultation. You are the last one to see the patient, so you are the one to be blamed as a pharmacist if there is any problem that you did not detect. Healthcare professionals have all the responsibility, but again, you are the one to see the patient in the end. And also, we have to actually measure the drug use and the changes on the patients, and we have to see the feedback and the outcome, and try to change the plan of your patients according to your patient's need. There is nothing called one fit all. You have to have a plan for each patient. Improve the drug use, improve the quality of care and frequency of lower cost, but with a cost-effective concept. Again, we spend an awful amount of money to prescribe a drug, but unfortunately, a little money to when to stop it or when to follow up those patients properly. The domino model that I use always in the clinic, and I always try to make sure that my interns and my residents are really getting the message properly, that we are not only dispensing, we are counseling the patient. We are even there in the follow-up clinic. We are part of the follow-up plan. And of course, the majority has to be measuring the outcome of the patient. Then after that, there has to be a research part and documentation part where you tell the others what mistakes did you commit, and so that they will avoid it in the future. Thank you very much. And I hope that I was sticking to the time.
Thank you, Dr. Fakhr, for addressing this interesting topic. Actually, I'm sure not most of us, they would have, good knowledge now about how to decrease the medication errors. And you really did a good job in improving our knowledge in how we know about polypharmacy, and for the better help and better counseling for geriatric patients. So thank you so much. Dear participant, now we will answer the questions. So kindly, please post your questions in the Q&A icon. So our speaker will answer them in a few minutes. Now, we have a couple of announcements. I have a couple of announcements for the audience for the registration. Dr. Fakhr, if we can move to the next slide, please.
Sure.
Yeah, okay. So the registration for the 5th National Patient Safety Award is open with the shown tract. and the deadline for registration is 30th of September. So this is an invitation for the registration for the 5th National Patient Safety Award. And also, I would like also to make a quick announcement that the Saudi Patient Safety Center will remind you, next slide please, remind you about the coming webinar that aligned with the World Patient Safety Day. So kindly find the schedule for the webinars, and you may visit also the Saudi Patient Safety Center website to view and submit. With this, I will go to the Q&A part. So again, if you have more questions, please post it so we can answer it. Dr. Fakhr, I think one of the advantage of being, a moderator is you get to ask first. So I will start with my question first before I go to the audience. Actually, something attracted my attention when you spoke about screening tool for elder patient. Now, is that only for the King Fahd Cardiac Center, or did you share it with other institutions? Because I find it's very important that if we could, disseminate the message through any way, maybe through the Saudi Patient Safety Center, or so. I think it's a good tool, but are you the one only using it, or do you share it with other institutions?
Very nice question, Prof. Ibrahim. It's not only for cardiac patients, honestly, it's for geriatric patients. Why did I use it for cardiac? Because as I told you, I'm in the cardiac clinic, but it's a tool that is available globally. And by the way, there's no copyrights for it. And myself, I've been training now, lots of residents and interns use it even outside King Saud University, which some of the clinics, one of our colleagues already tried it in Al-Batin in Dammam, and she got maybe similar results. Another of our colleagues, she tried it in King Fahd Medical City, and she tried it on oncology patients. So it's not the specialty. It's actually you need to first of all understand it. Yeah, in our case, you can see I did a table, the most common medications that we are actually focusing on in cardiology. You should do the same if it's oncology, for example, if it's endocrine. So the type of patient is not actually the disease, it's more into chronic patients with geriatric age or pediatric. It's not done in Saudi Arabia yet. But again, we can, if you are, inshallah, having some more time, we can even use it if you want with our colleagues attending the webinar, or even Merkaz al-Sahha Saudi. So we can apply it on a larger scale.
Yeah, I think it's a good idea. If we can share it to them, it will be a good idea. So let's go to the audience question. Now, have a number of good questions, actually. All of them are good questions. So I'll start with the first question. Is polypharmacy a problem among inpatient, particularly those on injectable prescription? And if yes, how do we limit the problem in this group of patients?
This question, it's coming from an expert, a person who did really face a problem like that with his patient. If I have faced a problem with oral tablets, sure, I will face it with injection, maybe even double the time. Nobody likes to be injected, especially, for example, when you transfer the patients from oral tablets for diabetes to insulin. Now, it's more accurate that you will deliver the dose because it's injectable. But the other problem is that patients do not like injection. Sometimes we used to threat the patient, if you don't have a proper results for your diabetes, we'll switch you to insulin. So it is a problem. What we're trying to do now, and this is actually very nice, you can see, for example, now the drugs that are used to decrease the weight with the diabetic patients. We used to give them, for example, Victoza, which has been given every day. Most of the patients now are switching to Ozempic, which is once a week. So what you try to do in the injectable medications, go with the less frequent, and this will improve the outcome of your patient's adherence.
Okay, thank you. Yeah, I have also, I don't know if it's a comment or a question. Polypharmacy is mandatory for some patients and cannot be avoided. For example, diabetic patients develop hypertension. Naturally, this patient will to have polypharmacy. It cannot be avoided. I'm not sure if this is a question or a comment. So if you would like to comment on this from our brother Muhammad.
I think what they're trying to say is that it's always start with one disease and then it's be complicated to more than one disease. And this is true. يعني usually what happens, you don't find a patient who's only diabetic. للأسف يعني, and I'm really sad to say that in our culture. Once they have a patient with diabetes, a few years after, you will get a cardiac problem, then you will get a nephro problem, because we're not managing the patient right. And you can see they are in the cardiac clinic within experts and with people following up the patient, and only 20% in the appropriate prescription medications. So we're not doing a good job. That's why I'm sure it's a complex. If you take care of the diabetes properly, most of the other disease will not appear. Maybe this is the comment for our audience.
Okay. Now I have a question also, which comes, from a number of participants. What would happen if I only took omega-3 every day? Since you mentioned omega-3 in one of your slides, and I was expecting some question will come. So what would happen if I only took omega-3 every day?
طيب, أول حاجة, let us first start with the following. Again, omega-3 by itself is not harmful, but it's not perfect. It's not the solution. And on the other hand, some of our, this question is two-part. First, am I a patient with hyperlipidemia and complications, or am I just a patient who's trying to prevent hyperlipidemia? If you are just a patient, or not a patient, you're just a person who wants to prevent hyperlipidemia, omega-3 is good for you, but there's types of omega-3, not all the types. وهذه يبغى لها طبعا another presentation. Then في DEA وفي EAA, what kind of cholesterol that you are actually attacking. So omega-3 by itself, it's not harmful, but it's also not preventing the hyperlipidemia. Okay, this is one. The other part of the question, some of the patients take it and stop their hyperlipidemia medications, or sometimes they take it on the top of the hyperlipidemia medication. They interact with each other. And there's only one type that will not interact, which we don't have in Saudi Arabia yet. So it's harmful for those patients. They know in the end, you're trying to stop the atherosclerosis. Omega-3 will not stop it. Omega-3 will prevent it only. But if it's there, it will not function. So the answer to the question, simply try to take a recommendation from an expert about this omega-3 rather than just taking it by yourself with no follow-up.
Yeah, if you could allow me, I would add one point, because I remember, a few days ago, this question, came to us about omega-3, as a replacement or as a source of the vitamin B source. So one of the recommendation from the speaker was, while eating more fatty fish is a good idea for omega-3, some are likely to have higher level of mercury or other toxin, like wild salt fish. Or so it was one of the recommendation that even if you would like to take a natural sources for omega-3, you have to be very careful about choosing what is the right fish, like salmon or walnut or other type of things. So if you would like to comment on this also, I would appreciate that.
يعني again, the source of your omega-3, or even that's why I'm telling you, it really needs a presentation by itself. Either the raw nuts, the type of fish that you are taking. By the way, even where this fish come from. يعني سبحان الله, البحر غير النهر غير المالحة غير الحالية. ف what age is the fish in, how did we prepare the fish, هذه كلها it has its effect on the outcome. So لاختصار الموقف بس, لأنه الآن I'm sure we are limited with time. Just take it with proper counseling and proper information of your source. Your source of information is very important. يعني يا إما expert من pharmacist أو your physician.
I agree. I think we need another lecture for omega-3. And okay, let's go to very quick on some question. Is polypharmacy a medication error? How can we recognize polypharmacy?
Is polypharmacy a mandatory?
No, is polypharmacy a medication error?
No.
How can we recognize polypharmacy?
No, it's not. If it's done properly, it's not a medication error, because as I told you, some patients need antihypertensive, anti-hyperlipidemia, anti-diabetics. I'm talking, I already have 3 drugs in my hand and a painkiller, for example. So it's already above 10. Polypharmacy is a medication error when it's not done properly. It's not accepted that they have 2 antihypertensive medication from the ACE inhibitor, for example. This is a polypharmacy that's a medication error. So what we're trying to do in our lecture, filter the polypharmacy to be a real polypharmacy one. Number 2, work on decreasing the errors that will happen from a polypharmacy, which is done properly. Again, كم واحد مننا يمكن الآن if you talk to maybe ما شاء الله الآن حضور 742, I'm sure 30% of them, they're taking more than 3 medication as a painkiller, as a flu relief, as a vitamin C, for example, or zinc. So again, this is a polypharmacy, but what you're trying to tackle in our presentation, that if you want to have a polypharmacy, make it proper, تكون scientific polypharmacy, and then after that, work how to decrease the complications of a polypharmacy.
Okay, I think this will lead me to another good question. I think you answer most of them, but it will be a good idea to elaborate more very quick. What is the most effective method to manage the polypharmacy, and what is the nurse role in preventing polypharmacy?
Great question. Education, education, education is actually the answer for this question. سبحان الله وكل ذي وفوق كل ذي علم عليم. Whatever you study, whatever you think that you know everything, it's not true. We have been sitting more than 10 years telling the patient, start aspirin. Aspirin is good, it's good for prevention. Now there's studies telling us it's contraindicated unless the patient has an event of MI. Unless he's ischemic heart disease, don't take aspirin. Imagine. فبالتالي my point, we have to always update ourselves. We have to always work on the education for ourselves first. Second, for the healthcare practitioners. You have to tell the healthcare practitioners, for example, this drug will interact with this. This drug should not be given in the evening. This one should not be given with food, and so on. The third party, which is very important, the patient themselves. It's not proper that my patient come to me and said, I took holiday a week ago because I did a good result in my blood pressure reading. Not accepted, of course. Why? Because I did not educate them that there's something called a reflux. You might go into hypertension crisis when you stop it for 1 or 2 days. So I think this is important, the education. The role of nursing, they are very important because they are the one to book appointment for the patient. They are important also for the lab. If they don't follow the lab and they don't follow the appointment for the lab, the patient might miss an appointment. And again, this is considered non-adherence.
Yeah, another question is polypharmacy and compliance are a big problem that we face in practice. How do we resolve this problem?
Wallahi, a good question. And I think part of it is what we're doing today now is part of it, the education, the webinars, the announcement, the awareness. The other thing is that we need to train our pharmacists. We need to train our healthcare practitioners how to talk to patients. What should they do in the counseling? You don't discharge a patient without talking to them and their family members. Another thing is very important for us is that in Saudi Arabia, we detect something very unique. للسعوديين, I think maybe information to pass in this webinar. We have an over-compliance patient. تخيل بعض البيشنت انت بتقول له خلاص we're going to stop this medication, يقول لا أنا مرتاح عليه. خلاص you don't need, لا أنا أبغى كذا. We have something unique in our culture. And by the way, this is not good because this is over-compliance. So again, more harm to the patient. What we need to do, we need to practice, we need to sit more with the patient, we need to see what problems we have and how to solve it. Part of it, زي ما قلنا اليوم, هذا screening tool. It's very nice. I really recommend everybody to use. And then from there, you can start even a project. You can start even giving advices that is validated through an expert في المجال. After that, of course, we would sure need to sit and talk in a higher level for more instructions, like nobody is allowed to dispense medication without counseling, for example. There's a fee for that for some of the community pharmacies. They take fee for this. So again, why? Because it's important. Patients should not be on a burden of having such a problem. They should be on a safe hands.
Okay, I think we still have some time, so I would kindly ask you to answer the question, in a quick way, because we do have a couple of good questions concerning community pharmacists. Don't you think that they need help in ensuring their good knowledge to help in such great project like minimizing polypharmacy? I think this is a very good question.
والله يا بروف إبراهيم أعتقد أنت كنت في الجمعية الصيدلية السعودية and I think the best one to answer is you لأنه أنت ما شاء الله تبارك الله أبو صيادلة هنا في المملكة. Please give us your insights about this.
Yeah, I think we'll take it to the president of the Saudi society now. But yeah, I agree. They need really help. Okay, another question is there any problem in prescribing IV and oral medications for anemia at the same time?
You mean يعني السائل ايش قصده بس يوضح لنا medication error منها يعني ولا انها
Yeah, I think he's asking, is it a medication error to have IV and oral anemia for medication for oral anemia at the same time? I think he's asking about as a medication error.
يعني having them together. طبعا this is a medication error because we know that if you're going to start an IV iron, and this is important by the way, very nice to raise it, you should not advise the patient to take oral. لأنه after that طبعا absorption of an oral is 3% only, whatever salt of iron the patient is using. But if I'm giving a bulk of IV, after this dose, patient should not take oral IV, if this is the question. He takes IV, stop the oral, evaluate them after 6 months or 3 to 6 months طبعا تعتمد what's the reason of the anemia they have. And then after that, we might recommend oral, so he will maintain the level that he reached.
Okay. Okay. I think one of our colleague here, our colleague Asma, also, I think she seconded, our suggestion that we need a lecture about types of omega-3 and how, patient it will fit each patient. So this is a kind, request from Saudi Patient Center to help us maybe in organizing, this very important subject. Okay. Now, another question is, how do we measure the medication or drug use to evaluate the efficiency of an intervention to reduce inappropriate polypharmacy?
Wow, that's a great question, and it's a very complicated one, honestly. يعني نسال أكيد professor في الجامعة. And I agree that we have to measure. By the way, we have different methods. In Saudi Arabia, the most common اللي هو Morosky score. Again, it has its copyright, and what we do, we measure the adherence of the patient to the medication. Okay, here specifically for the medication. But again, what medication he's adherence to and what's the measurements outcome, we don't know. This is only a question and answer. في بعضها, some of the medications, by measuring the level of the medication, or sometimes for an outpatient, we used to do it. We used to tell the patient, bring us your old bottle of your drug, and you count the tablets. You see if the tablets, for example, missing 1 or 2, it's fine. But if he comes with the full tablets, box كاملة, that means your patient did not take the medication. أو عنده another file in another place. This is kind of, here lots of tools تعتمد where are you actually performing these measurements. في الأجنحة, for example, we used to ask for the level. والليفل مهمة جدا في بعض ما هي بس only for the therapeutic index. Sometimes to measure, is the patient taking your medication or not?
Yeah, it's good news to Asma and to us, Saudi Center, our coordinator Hiba, answered me immediately. She said, yeah, we have no problem in organizing a lecture about omega-3. So thank you so much for taking care of us. Thank you. Okay, now I have one more question, then we will end. Regarding the critical cases, how I will handle polypharmacy with emergency case, especially doses?
This is a very hard question, honestly. And, you know, maybe in our specialty, the most critical one is the acute coronary syndrome, where your patient come with an MI. And myocardial infarction, it's the end of a story for some patients. It's not easy. You have to be so expert because you have to be there to make sure, for example, I do really match it with the poisoning management. يعني time بيقول لك time is a myocardium door to balloon and here the 90 minutes or 120 minutes which the attack appeared, you did the intervention. Part of the proper intervention is giving the medications during this 120 minutes. What we do sometimes just to make life easy, because we're a human being in the end and we don't memorize everything, we do a checklist for that. Yani patients came with aspirin, for example, he took his proper dose of aspirin, proper dose of clopidogrel, and so on. So we put a checklist for everybody to use. It's easy, it's clear with doses, very important to put the dose on, by the way. And make sure your patient take it on the proper time. Because, for example, if I don't load the patient and I'm taking them to the PCI, which is there to do a stent, يركب دعامة, and he's not well hyperinated, for example, what are we doing? We are facing another problem. Yani, you have to be there to make sure that these kind of complications are there and you are stopping it, you are preventing it. It's not easy and it needs a lot of experience and a lot of effort. But we can do it because most of, mashallah, tabarakallah, of our clinical pharmacists now, they are competent enough to do it even in the emergency, even in the critical situations.
Okay, I'm trying actually to answer all questions, but the problem is we do not have time. So just maybe if you promise me, you will answer them very quick. Okay, somebody is asking about sharing your email, so thank you so much. You are sharing your email. So this is a problem. Another colleague, suggested that we should share, some success story of polypharmacy. Yeah, it's a good idea, but maybe it's not going to be within 1 hour a lecture and sharing the story. So it's a very nice suggestion. Last question, I will go. Can you please asking me to introduction of paracetamol suppositories and syrup at the same time for fever and pediatric?
Which is the better outcome to, you can combine the paracetamol with ibuprofen, for example. But giving the same drug in different route will not give you a better effect, by the way. It will just increase the toxicity. وهذه خطأ للأسف معظمنا بيحصل معه. يقول لك, okay, I took a dose, it did not work, I'll take another dose. أو مثلا زي كده, he took oral, then he would combine it with suppository. This is not right. What is recommended from, again, evidence-based, is that you tackle one pathway, which is the paracetamol, prostaglandin, and then you add on the non-steroidal anti-inflammatory, which is, for example, ibuprofen, indomethacin. It depends on طبعا Voltaren, يعني what is available. Now we have 2 different dosage forms and 2 different classes.
Okay, I want to take your permission and the audience permission before we conclude. I would like personally, on my behalf and on Dr. Fakhr behalf and all speaker behalf, to thank our coordinator Hiba Jaberti for all the great help. We have to speaking about this webinar maybe a month ago, and she never hesitated once to answer any question we need. She was always with us, every single minute. So from the beginning until the end. So thank you so much, Hiba, for our colleague, Hiba, for all the great help. Thank you also for all Saudi patient, safety center members, IT, everybody worked very hard for, having a good presentation and, offering, a very nice, sticking with time and, answering all the questions in the chatting. So thank you so much. And on behalf of the Saudi Patient Safety Center, we would like also to thank our great speaker, Dr. Fakhr Al-Ayyubi, and the audience for their active participation. As a part of the Saudi Patient Safety Center effort to provide with the timely topics and interesting speaker. We would appreciate if you would fill out the evaluation survey that will be sent to your email after the session. So thank you for joining us today, and we look forward to welcoming you back in the future webinar. Thank you so much, and good night. Bye-bye.
Thank you very much.
Bye.